Our group did a study a few years ago in which we took patients with Waldenström's macroglobulinemia who were on ibrutinib, and we wanted to understand what factors could relate to predict the progression-free survival on these patients. So we started looking at a number of different aspects, and we were interested specifically on looking at the depth of response on the treatments as a predictor of the progression-free survival. And in that study, we looked at 2 different time points. We looked at the response at 6 months on therapy and at 12 months on therapy. But we also looked at 2 different depths of response. We looked at partial response, which is a decrease of the IgM by 50%, and very good partial response, which is a 90% decrease on the IgM. So basically, we did a 2-by-2 analysis. And from the 4 different combinations that we have, we found that attaining a partial response at 6 months was the best factor to differentiate between patients who will do well or will do better in terms of progression-free survival. These are the patients who attain a partial response at 6 months or within 6 months, and then patients who did not, and those are the patients who had a worse prognosis. So with this in mind, we did a validation, so we did a learning cohort and a validation cohort within that same study. So we wanted to investigate if we could use this same prognostic factor in patients who are participating in the iNNOVATE study. That's the patients who actually got treated with ibrutinib and rituximab. This is a combination. We wanted to look at the patients who were treated with acalabrutinib, which is a second-generation BTK inhibitor, and also in the context of the ASPEN study, the patients who were exposed to zanubrutinib, which is also a second-generation BTK inhibitor. So we kind of follow the same methodology in these 3 different populations of patients. And what we found is that when we looked at the iNNOVATE study, which is ibrutinib plus rituximab, 75 patients, when we looked at those patients, we could see a separation of the progression-free survival curves, favoring the patients who attain a partial response at 6 months, but that separation was not statistically significant. Now, you can make a case that maybe with a larger sample size, we have seen maybe a statistical significance in those patients, but there was a hint of a difference in terms of the prognosis of these patients. When we looked at the acalabrutinib study, which is about 96 patients, in that study, there was a little bit of a separation, but that was actually a much less separated than from the iNNOVATE study. And again, this doesn't mean to be an inter-study comparison, and that was also not statistically significant. And when we looked at the zanubrutinib data, which is about 102 patients in that database, we did not see a separation at all. Right? So as a comparator, we used the ibrutinib arm from the ASPEN study, and in that ibrutinib arm, we did see the separation. So we validated in the ibrutinib monotherapy arm our findings from the prior study. But when you add rituximab to ibrutinib, that separation seems to be a little softer. And when we think about the second-generation BTK inhibitors like acalabrutinib and zanubrutinib, the separation seems to be even softer. So I think the message of these 3 studies together is that when we use ibrutinib in combination with rituximab or the second-generation BTK inhibitors, the depth of response does not really predict the progression-free survival of these patients. And I think that's an interesting message, because I got a message a couple of days ago from a colleague of mine saying, I'm treating these patients with Waldenström's with zanubrutinib, and the IgM went from 4,000 to 1,500. That's a partial response. Should I do something else? Maybe the depth is not good enough, and I need to do something else in order to have a better outcome. And I think what we can learn from these studies is that if the patient is doing well, symptomatically speaking, if the patient's blood counts are stable and all his organ functions are well and he's performing very well, the fact that you do not get to a partial response or you do not get to a very good partial response, that should not be a reason to consider other treatment options, because these patients will do well in the long term.